All right, so I'm going to be speaking about hydrocephalus after hemispheric surgery and other large operations. It generally doesn't apply to surgeries outside of hemispherectomy. I personally haven't seen it. I'm sure there are cases out there of other large resections, but it's commonly associated with hemispherectomies. Okay, so briefly, I'm going to review cerebrospinal fluid or brain fluid physiology. What do we know about post-hemispherectomy hydrocephalus? And what do we need to know about post-hemispherectomy hydrocephalus? So everyone makes brain fluid every hour. It's made primarily in the choroid plexus, although there's other sources as well. That's the tissue in red in the middle of the head. And it's primarily absorbed at the surface of the brain at the arachnoid villi, but there's other places of absorption as well. And for each drop of brain fluid that's made, the same amount needs to be absorbed. And if it doesn't, then you have a problem. You have hydrocephalus. Very briefly, the skull is a closed space, and if there's anything that takes up more room, either a tumor or whatever it is, including hydrocephalus, can press on the brain. And over time, if there's more and more pressure, it can cause a life-threatening problem and concerns for herniation. That's when the brain squeezes into the spinal canal, and that can be fatal. That is fatal. So hydrocephalus is really an imbalance between the production and absorption of brain fluid, and it may or may not present with a change in the ventricular size. And that's important to know, just so an MRI by itself can't completely rule it out. There is no cure. It's a lifelong condition. So I always talk about if you can treat the child's epilepsy, which is a lifelong condition, but if you leave them with hydrocephalus, that's another lifelong condition. You've swapped them epilepsy for hydrocephalus, and hydrocephalus is also quite dangerous to live with. And the only effective treatments are surgical. So what causes hydrocephalus? On a fundamental level, you can have increased brain fluid production, which is actually quite rare. You can have impaired absorption, or you can have obstruction in the fluid pathways. Now, each one of these three can really happen post-hemispherectomy. Surgery often induces an inflammatory process and can sometimes increase the amount of brain fluid being made, at least temporarily. Blood and protein can obstruct CSF absorption at the level of the arachnoid villi, which I showed. And also disconnecting brain areas from one another can also affect CSF flow dynamics. So you can really have any one of these in a child that develops hydrocephalus. Now, these kids end up in the emergency room quite often. Anyone who's had a child with hydrocephalus knows that it's usually in the middle of the night, your kid's sick, vomiting, you're not sure, is it the shunt or not? And shunt problems manifest in three flavors. One is the child that obviously has something else going on. They have gastroenteritis or they have flu symptoms, and the ventricles look pretty stable from before, and that's not a shunt problem. That's easy to diagnose. You also have the child who's projectile vomiting multiple times, retching, comatose, with acutely enlarged ventricles, and that's easy to diagnose too. That's a shunt problem. You go into the OR, you fix it. But often you get this, where you have a child who is maybe having some headaches. The MRI doesn't show anything. Nuclear studies don't show anything. Shunt taps look okay. Or maybe they just have some behavioral changes. And this is the more common thing that we deal with, and as you can imagine, the amount of frustration that is associated with. I think it's out of battery. Oh no, there we go. So the evolution of hemispherectomy surgery has gone from anatomical approaches down to now the endoscopic assisted hemispherotomy, and all of this was really done to decrease the morbidity associated with hemispheric surgery, which in general, the less brain tissue that's removed, there's less blood loss during surgery, less likelihood of developing hydrocephalus. At least that's conceptual. A few facts. The most common way we treat hydrocephalus, although it's not the exclusive way we do it, is with CSF shunts. These are permanent implantable devices in the body, and you become permanently dependent on it. Technology that's been around since the 1950s, and very little progress has been made. permanent dependence on this device. This device has the highest failure rate from all medically implanted devices anywhere. Estimated 50% of shunts will fail within 2 years, and is a high risk of infection because it's a foreign body being implanted. So it's not great, but we need it. There's endoscopic treatments that sometimes may be appropriate. I'm not going to get into the details. And then there's this other procedure where we're doing it more commonly now, where you can cauterize the choroid plexus to decrease the amount of brain fluid being made, and hopefully what's being made can be absorbed. And these are kids that can get away with treating their hydrocephalus without an implantable device. We still don't use the word cure for hydrocephalus. We never use that word. Okay, so anecdotally, said, there's not much evidence there, but what can reduce the risk of hydrocephalus following hemispherectomy? So disconnective surgeries as opposed to resective surgeries, decreasing blood loss around the time of surgery, decreasing the amount of blood that gets into the ventricular system and causes that inflammation and potentially obstruction, and aggressive drainage of brain fluid following hemispherectomies. Now, if a child were to develop hydrocephalus, what we don't know is, let's say we're going to treat it with a shunt. Where are we going to put the shunt? Are we going to put it in the ventricle side, the normal good side of the brain, or are we going to put it on the cavity side? I'm pretty sure Monica's given me this statistic, but I think 2/3 have it in the cavity side, about 1/3 on the side of the ventricle. And we don't know what's better. Obviously, the cavity side, the pros are that there is no brain on that side that you can hurt, but also these shunts are really made to be in the ventricle, and they obstruct more commonly if they're in the cavity side. This is one of 2 studies published in post-hemispherectomy hydrocephalus. Actually, a pretty good one. So one of our colleagues, Dr. Liu, and a large group looked at post-hemispherectomy hydrocephalus, and they found that about 20 to 30% of patients develop post-hemispherectomy hydrocephalus. However, some of the data here may be flawed because a lot of these patients are from UCLA, and one of the previous surgeons used to prophylactically put in shunts in every patient. And this was when 1986, right? So this is one of some really dated literature now. So when you look at that, the numbers seem a lot higher than they actually are. To be honest with you, when we've looked at our recent numbers, it's closer to 3–5% maybe. So a lot of my colleagues that are doing this now think that the 20–30% is a really over-exaggeration. Not sure a lot of those kids needed shunts to begin with. But once you put in a shunt, that child's shunt dependent. The most common indication to put in a shunt is failure to wean CSF drain. As you can imagine, that can be highly subjective. Do I give a child a chance for 1 day to see if they'll absorb fluid if I challenge the drain and determine they have hydrocephalus? What is the criteria? There's no objectivity when it comes to this. Is headache an indication by itself? So the factors that may be associated from this study are anatomic hemispherectomies, right? So that the initial surgeon, Dr. Peacock, that Dr. Sankar was talking about, would put them routinely postoperatively in these patients. So not surprising that anatomic hemispherectomies, that's when we first started doing these, are associated with higher shunt rates. Whether the deep brain structures, basal ganglia and thalamus, get resected. Prior surgery is actually a really important one. The risk of hydrocephalus is cumulative with more surgeries. So when we've had 4 or 5 hemispherectomies, those children almost invariably have shunts. It would be rare not to have a shunt at that point. Things that are unlikely to be associated: postoperative infections, postoperative CSF drainage, and etiology of epilepsy, so what the underlying cause was, which is precisely the opposite of what this next study found, that actually the etiology, the source of what led to the epilepsy, is related. So this is a study out of UCLA, and they found that hemimegalencephaly, children much more likely to have shunts compared to some of the other cortical dysplasia, Rasmussen's encephalitis. As a caveat, I just want to let you know that all these studies that we're talking about with very few patients, we take them as, this is the data, this is what it shows. But in scientific literature, studies can be conflicting. Actually, the most popularly cited article in Auto Medicine is why most published medical literature is false. So that's something to keep in mind. Science goes at a very slow speed, and you need to repeat your findings for it to be taken, as fact. Briefly going to talk about brain shift, and Monica talked about brain shift and her son. This can be severe, right? And certain kids, and what we don't know is what is the manifestation of these? Do these kids have headaches? Do they have behavioral problems? Do they have cranial nerve palsies? And we don't know that. But we looked at our 250 children since 1986 that have undergone hemispherectomies at UCLA, 28 anatomics, 222 functional, and that's the shunt probability. But we had an excellent opportunity here. You can't see this, but it shows you that depending on the etiology, the level of brain shift is variable. The children that are most at risk are the ones with strokes. When you actually look at when a shunt is placed, when a shunt's placed in the cavity, those children on average have over 1 centimeter more of a midline shift compared to kids that do not have shunts. And what's worse with the shunts are actually the delta shunts as opposed to the programmable ones, the ones that have a fixed flow every hour. So what do we think we know? That anatomic hemispherectomies lead to a higher likelihood of developing hydrocephalus. We are conflicted as to the evidence whether the underlying etiology may affect the risk. We know repeated surgery increases the risk of hydrocephalus, and failure to wean, the postoperative drain, is the most common presenting sign. But what do we need to know? What is the current prevalence of hydrocephalus? I think it's a lot lower than what's written about in the literature. Number two, what are the controllable risk factors for developing hydrocephalus? The biggest advancement we can make as clinicians is preventing this in the first place. And can we lower this incidence of hydrocephalus through the establishment of evidence-based protocols? How do we implement these protocols at these centers and see if we can reduce the risk of hydrocephalus? What is the criteria of diagnosing hydrocephalus? We don't have that. Is it clinical? Is it radiographic? Is it ICP monitoring? We don't have that. And when you take your children to 10 different neurosurgeons, you're going to get 10 different responses and 10 different treatment plans. We have no consensus. We only have consensus in the extreme situations when a kid is acutely sick. But other than that, we don't. And lastly, how do we treat it? In this day and age, there's ETVs, CPCs, ways to treat hydrocephalus without a shunt. Now, if we need to put a shunt, where do we put the shunt? What valve do we use? None of this is known. And lastly, how do we measure the patient-important outcomes? The number of shunt surgeries isn't the right outcome to study. It's the development. It's the cognitive outcomes. So our studies currently are focused with the number of surgeries that are required, but that may not be the right question to answer. In conclusion, so hydrocephalus, I think, is one of the most devastating complications following hemispheric surgery, and it actually affects every domain that we have up there: motor outcomes, cognitive, all of the things we talked about. Endocrine, for sure. Research is severely limited. We have 2 articles. One of them is a multi-center study. Large, multi-center, hypothesis-driven research is required to address knowledge gaps. Thank you for your time.